So how you doing? I'm Tyler Tepfenhart. I'm an internal medicine resident over at Baylor Scott and White Round Rock, affiliated with the Texas A&M Health Science Center. I did this case report with Dr. Callie Fort, another IM resident, as well as a medical student, Marcel Twahirwa. So here's our case presentation. It is an unexpected cause of recurrent chest pressure and dizziness in an elderly man. So let's dive into it. Let me move my little camera out of the way so that I don't block my own view. So here's our case presentation. It's a 71-year-old male, presents with a history of grade 3A follicular lymphoma, currently in remission, status post 6 cycles of R-CHOP via port-a-catheter. He's got a history of thyroid cancer, status post radioactive iodine ablation in the distant past, as well as hypertension and hyperlipidemia. Presented to the oncology office for a follow-up regarding his lymphoma. In the past 10 weeks, he has had about a 10-week history of intermittent chest pressure and dizziness. At the onset, so about 10 weeks ago, he went to the ED where he said he was having this burning chest discomfort. His vitals were within normal limits. The physical exam was unremarkable. They did some basic workup with a D-dimer and troponin, which were both negative. They also got a CMP, and which was also unremarkable, and a CBC, which showed his mild, stable macrocytic anemia. So nothing new from past checks. They also did a chest X-ray, which showed a port-a-catheter in place. No acute cardiopulmonary process was identified. So over the next few weeks, he continued to have bouts of intense chest pressure. So it became went from this burning chest pain to an intense chest pressure. He began also having lightheadedness, flushing with any type of exertion. And he also said he would seemingly get random spells of the pressure even at rest. These episodes would last anywhere from 2 to 5 minutes at a time and self-resolve without any intervention. He measured his systolic blood pressure using a home cuff, and he said he was getting readings about of 170 systolics. Previously to these episodes, he had well-controlled hypertension on carvedilol, losartan, and amlodipine. He followed up with his cardiologist 3 weeks after his initial ED visit, and was due to receive an ambulatory cardiac monitor. Following this visit, the patient had more severe episodes of chest pressure where he was alarmed to see his systolics about at 210. This prompted him to call the EMS, but on EMS's arrival to his house, his symptoms had resolved. They checked his blood pressure. It was within normal limits, and he just refused transport at that time. Due to that initial negative workup, despite his symptoms having changed from his initial presentation to the ED 10 weeks ago, he didn't think they were significant because he had that negative workup just 10 weeks ago. The patient presented to the oncologist's office, and as we said, for regular follow-up. He was presenting to undergo a CT scan as well, just to measure to monitor the status of his lymphadenopathy in regards to his history of follicular lymphoma. In the vitals checks, everything was within normal limits. His blood pressure, 122/72, pulse of 71, temperature 98.1 Fahrenheit, SpO2 96% on room air, and a BMI of 41. Physical exam, really nothing to note. He didn't seem to be in acute distress. Obviously, he wasn't having one of his episodes when he was presenting there. The heart and lungs, normal S1, S2 was regular, no murmurs, and the lungs were clear auscultation bilaterally, no wheezing or crackles. Everything else benign, no lower extremity edema, abdomen was soft, non-tender. So that brings us to the CT scan, which, good news for him, showed no changes in his lymphadenopathy, however, had an incidental finding. So as you can see in the CT, we have a nice incidental finding. So the CT scan of the abdomen with contrast, it's an axial view. It showed a coiled port-a-cath in the pulmonary artery. On A, figure A over here is the superior view. Figure B over here is an inferior view. So the oncologist was obviously immediately notified with an urgent referral to the interventional radiology. He underwent a retrieval of the port-a-catheter fragment following day with interventional radiology. Since the procedure, the patient has not experienced any episodes of chest pressure, lightheadedness, or flushing, and has been able to return to his active lifestyle. And just a little bit of discussion to talk about this fractured port-a-catheter. So it's an estimated incidence of about 1.8%, with migration to the pulmonary artery occurring at about 0.2% of the caths that are fractured. The most common cause of a fractured port-a-catheter is a device defect, followed by inappropriate techniques placing the catheter as well as accessing the catheter. And lastly, by various patient factors, most commonly trauma. A majority of fractured port-a-catheters are asymptomatic, but serious complications have been documented. These complications include arrhythmias, cardiac perforations, and thrombosis. This reinforces the need to obviously retrieve to prevent these complications. Studies show that a success rate of minimally invasive fractured port-a-catheter removal is about 98%. So this is via interventional radiology. Although we are unsure in this patient what caused the fractured port-a-catheter, we suspect it was likely due to a device defect. It's interesting because he underwent all 6 cycles of his chemotherapy using the port-a-catheter without any issues. And he denied any increase in physical activity and denied any trauma that onset his symptoms. And it's with the resolution of the patient's chest pain and dizziness upon a retrieval of the fragmented port-a-catheter, obviously it seems highly likely that this was the etiology of the patient's symptoms. So we always like to bring it back to physiology. Very well could be, so we talk about the presence of the catheter in the pulmonary artery likely directly irritated the endothelium, resulting in chest discomfort. Pressure within the pulmonary artery likely was increased due to the presence of the coiled catheter. Unlike carotid baroreceptors, the pulmonary artery baroreceptors respond with an increased pressure by increasing sympathetic tone, leading to vasoconstriction. The increased pulmonary artery pressure from the coiled cath could have resulted in our patients' recurrent episodes of these acute hypertension through this mechanism. These episodes of hypertension could have resulted in a hypertensive crisis presenting as chest pain and dizziness. Since the fragment's retrieval, as I said, there's been no other further episodes of his symptoms. He's returned to the gym and participates in his aerobic exercise without issue. Here are some of the references from the statistics I quoted in the discussion.